So the topic we are going to discuss today is sarcoidosis, and we are going to discuss the multiple aspect of it. A lot of it is taken from the ninth edition of Kamsky. A part of it is taken from Medscape. So first of all, introduction. Sarcoidosis is a chronic disorder of unknown cause, manifesting with non-caseating granulomatous inflammation, and it can affect any organ system, but the lungs and the lymph nodes are the most commonly involved. It more frequently affects patients of black than white ethnic background, that is at the ratio of 10 to 1, and is more common in colder climates. It is one of the most common systemic association of uveitis. Patients usually present with respiratory symptoms, and that is with cough, shortness of breath, especially on exertion, and constitutional symptoms that include malaise and arthralgia, and each of them occurs in about 50% of patients. A minority of patients are asymptomatic, and findings are incidental upon abnormal chest X-ray. Diagnosis can also be made as a result of investigation of extrapulmonary inflammation such as uveitis. So there are multiple syndromes which are associated with sarcoidosis, but we are only going to discuss a couple of them because of their association with ocular involvement. The first one is the Laughlin syndrome. It is an acute presentation carrying a good prognosis and characterized by a triad of erythema nodosum. As you can see, it is illustrated in the picture here, and which usually present on the shins. Bilateral hilar lymphadenopathy here, and usually it is seen in chest X-ray, and polyarthralgia. The syndrome is most commonly seen in women. The second syndrome is Herford-Waldenstrom syndrome, which is characterized by presence of facial nerve palsy, parotid gland enlargement, anterior uveitis, and low-grade fever, as illustrated in the picture here. Now, coming to the systemic features, the lung disease, as it is detected on the X-ray, ranges from mild parenchymal infiltration to severe pulmonary fibrosis. In this X-ray here, there is bilateral uh, hilar lymphadenopathy seen here. Number two involvement is that of the skin. Skin lesions are seen in about 25% of the patients and can include erythema nodosum, as I have already mentioned. These are tender erythematous plaques, typically involving the shins, as seen in these pictures, which are actually more clearly visible in the book. Lupus pernio, which is indurated bilaceous lesions involving exposed part of the body, such as the nose, cheeks, fingers, and ears. Here in this picture, it is more properly seen around the cheeks and in the nose area. And granulomatous papules or macules. Then the neurological disease, which is rare, but meningitis and cranial nerve palsies may occur. Pituitary involvement can lead to hormonal abnormalities. Then is the cardiac involvement. It is relatively uncommon, approximately 5% clinically. involved, but it is critical as it may lead to arrhythmia and sudden death. Last but not the least is the lymphadenopathy. Enlargement of superficial lymph nodes is sometimes the initial clinical manifestation. Now, we are going to discuss the ocular features, which are the most relevant part for the ophthalmologists. Ocular inflammation occurs in about 25 to 70% of sarcoid patients, depending on ethnicity. Granulomatous anterior uveitis is the most common manifestation. Blindness can occur if not adequately managed. Acute anterior uveitis typically affects patients with acute onset sarcoidosis. Chronic anterior uveitis, typically granulomatous, tend to affect older patients with chronic pulmonary disease. The International Workshop on Ocular Sarcoidosis, reported in 2009, identified 7 key signs in diagnosis of intraocular sarcoidosis, and we are going to discuss. So, the 7 key signs include the mutton fat capies, uh, and the small granulomatous capies or iris nodules. This is number one. Number two, as seen in this picture, are the granulomas in the trabecular meshwork or tent-shaped peripheral anterior synecdoche. So first of all, we went to cornea, then we went to the angle. Number three is the string-shaped or pearl-shaped vitreous opacities, including snowballs. Then is multiple chorioretinal lesions. They can be focal, they can be multifocal, and multifocal have bad prognosis. And then is the nodular or segmental periphlebitis. So first of all, in the posterior segment, there is vitreous, then we go to the choroid, and then we go to the vessels. Vessels have typical venous involvement and candle wax drippings. And then optic disc nodules, and it can also present as papilledema. Number 7 is other involvement, which include a lacrimal gland, conjunctiva, orbital, and scleral lesion. The 5 investigations that we require for the diagnostic criteria are the negative tuberculin skin test, elevated serum ACE or elevated serum lysozyme, chest X-ray showing bilateral hilar lymphadenopathy, abnormal liver enzyme test, and chest CT scan in patients with a negative chest X-ray result. So that's all for the sarcoidosis, and we'll conclude our topic here. Thank you.